Hey everybody, welcome back to the EKG review videos. My name is Reed. I really hope you enjoy these videos. If you do, please subscribe so that you can follow along for our EKG reviews and leave some comments or some feedback on how I can make this better. So let's jump into this review. So here I've got a good EKG. I'm going to go ahead and what I call take a look at the forest, and my forest are the trees, and so I like to start off with my lead 2 rhythm strip and just get an idea of what's going on with this rhythm. And so if you notice, I've got these little QRSs in lead 2 that are occurring quite rapidly, and if you notice, as I make tick marks, they're occurring somewhat irregularly. Some of them are longer duration, some of them are shorter duration, some of them are intermediate duration, and so there isn't a particular pattern to this rhythm. And so this rhythm, I would say, one is fast. We can calculate our rate to be anywhere between, this is maybe 200 beats per minute, and this one right here, this strip right here would be somewhere between 300, 150, 100, maybe 80. So this is going anywhere between 80 to 200 beats per minute when you look at individual beats. Right here's another really fast interval. And secondly, I would say it is irregularly irregular. And what do I mean when I say that? I mean that sometimes rhythms have regularity to the rhythm. You might have every third beat something goes wrong, then every third beat again something goes wrong. But in this case, these QRSs are just sporadically occurring at these interval rates and rhythm that kind of doesn't make sense. So it's an irregular rhythm, and we know that that is pathognomonic for atrial fibrillation. So let's see what we've got with this. So I'm going to look for atrial activity in front of our QRSs, and so if I look in front of, say, this QRS in lead 3, if I zoom in on this one, when I look in front, I don't see any atrial activity. And if I zoom in on some of my others, I don't see any good atrial activity in front of these. And I'm going to just scan throughout this EKG. V1 is notorious for having good atrial P waves in front of them when we have them. But I'm not seeing any P waves. And so there's no P's in the setting of an irregular rhythm. This, we can go ahead and say, is atrial fibrillation. And because of this really fast rhythm that we identified, we can say with a rapid ventricular response. We always want to say atrial fibrillation that is controlled, rapid, or slow. So now that we've identified this as atrial fibrillation, let's take a look at our QRS morphology, because we know that the QRS, the morphology of it has to do with conduction below the AV node, and atrial fibrillation is conduction that is occurring above the AV node. So let's take a look at our QRS complexes. And what we'll notice here is we've got these wide complex QRSs. If I take a look, if I zoom in at AVL, this QRS complex is greater than 120 milliseconds in duration, which we know is wide. And so wide QRSs that are being conducted from the AV node, the first thing I think about is, why is it going slow? Why is it taking too long? Is there something about that His-Purkinje system that is not being utilized properly? So I wonder, is this a bundle branch block of any sort? And so the first thing I like to do for bundle branch blocks is evaluate for a left versus a right bundle branch block. We know that left bundle branch blocks would have an RS, R prime in the lateral leads. And so when I take a look here, my lateral leads, which are leads in my limb leads 1 and AVL, what I notice is I've got these wide positive waves that are kind of this RS, and then you can almost see a little R prime at the end, kind of right there. Similarly, you can almost just see this little slurry wave here, RS, and you can just see it want to stay. AVL, you can see it a little better here with this RS, R prime. And if I look at this lateral lead in the precordium, V6, you can see it's just slurring on the way down. It's just taking a little long. And so then I'm starting to think maybe this is a left bundle branch block. Well, what else can I do? I can look for deep S waves that are nice and slurry S waves in V1 and V2. And that's exactly what I see. I see these prolonged, deep, negative deflections. And not only do I have these prolonged, deep, and negative deflections, what I've lost, if I look in front of those, what I've lost is I have no septal R wave. And we know that our septal R's, these are from the R waves that are generated in the V1, V2. Those are from the left bundle. And so the left bundle actually supplies the electrical conduction to the septum from a left to right fashion across the septum. And because those rightward forces of septal depolarization are typically captured positively as small septal R waves in these V1, V2 kind of anterior chest leads. But because we have lost those, we can now, in the setting of these slurred RS R prime, and these slurred RS R prime in the lateral leads, and the loss of a septal R wave, we can say that this is a left bundle branch block. And that would explain why our QRS is wide. And so what is my final diagnosis on this EKG? We first said that this is atrial fibrillation with a rapid ventricular response and a left bundle branch block. So I hope this helps, and have a good day.